It's time for another warm-up. Let's get going. Which immune deficiency is associated with each of the following findings? So first we have anaphylaxis on exposure to blood products with IgA. This is selective Ig deficiency, so this is a B cell disorder. Next we have coarse facial features, abscesses, eczema. So this presentation is seen with hyper IgE syndrome. So this one is also referred to as Job's syndrome, and this is a T cell disorder. Thrombocytopenic purpura, infections, eczema, so this one is the Wiskott-Aldrich syndrome, which is a B and T cell disorder. Next we have delayed separation of the umbilicus, so this is leukocyte adhesion deficiency type 1, so this is a phagocyte dysfunction disorder. And then we have neurodefects, partial albinism, recurrent infections, this is a Chidiac-Higashi syndrome, also a phagocyte dysfunction disorder. All right, next question. Bilateral Bell's palsy should raise suspicion for what condition? So you want to think about Lyme disease, also possibly Guillain-Barré syndrome. All right, that's it for the warm-up. Let's get to that lecture.
Coal seems to be a big button issue these days. Coal mines, Old King coal, Coca-Cola, collard greens, Cole's angiitis. What's that? It's cholangitis, not Cole's angiitis. They're not the same root word? Well, how do you think I would know that? Do I look qualified for this? I thought gitis was a weird name. Anyway, thanks for coming back. In our first lecture, we went over the hepatocyte production of bile products and their excretion of conjugated bilirubin. Now we're going to discuss the biliary tract, which is the glorified plumbing system that carries the bile from the liver to the gallbladder and duodenum. Let's start with the basic anatomy. Bile is made in the hepatocytes and is excreted into the bile canaliculi that line the plates of hepatocytes, which lead to the bile ductules of the portal triad, which then converge into larger and larger subducts until they form the left and right hepatic ducts of the left and right lobes of the liver, respectively. Then the left and right hepatic ducts come together to form the common hepatic duct outside the liver, and the bile flows from there into the cystic duct and the gallbladder. The gallbladder stores and concentrates the bile. It acts pretty much as a reservoir of bile and really not much else. As the bile flows down to the duodenum, it will also encounter a branching path that leads to the pancreas. The exocrine pancreas produces large amounts of digestive enzymes that join the bile in the duodenum to, digest. So importantly, removal of the gallbladder or cholecystectomy doesn't prevent you from making bile, it just prevents the storage and timed release of it. The gallbladder remains largely quiescent until it is called upon to perform its heroic duties of squeezing out bile by a chemical messenger. The primary hormone or chemical messenger that causes the release of bile is known as cholecystokinin, or CCK. CCK is released by the eye neuroendocrine cells of the proximal duodenum in response to partially digested proteins and free fats of the digestus. There's another important hormone that comes into play here, secretin. Secretin is released by S neuroendocrine cells primarily in response to the decreased pH of chyme. Rather elegant, isn't it? After proteins have been broken down into their components by hydrochloric acid and pepsid, the digestus passes through the pyloric sphincter into the duodenum along with the acidic digestive media. This stimulates the production of cholecystokinin and secretin. Cholecystokinin results in contraction of the gallbladder and release of bile into the duodenum, while secretin acts on the pancreas to cause release of trypsinogen and chymotrypsin for digestion and bicarbonate to neutralize the acidic medium. So when CCK tells the gallbladder to contract, bile is expelled from the gallbladder back into the cystic duct and then into the common bile duct. The common bile duct is where the cystic duct and the common hepatic duct come together. And then the common bile duct eventually joins the main pancreatic duct so that the bile and pancreatic juice mingle together, and then it all comes through the ampulla of Vater and into the duodenum. We can visualize the bile duct through the ampulla of Vater using a procedure called ERCP, which is endoscopic retrograde cholangiopancreatography. where an endoscope is positioned into the second portion of the duodenum, and we inject contrast retrograde through the ampulla vater into the common bile duct in order to visualize the lumen of the biliary tract, to look for any evidence of obstruction, whether it's from gallstones, from scarring, stricturing, or tumors. Let's discuss what bile is actually made of. Bile mostly consists of bile acids, but also contains phospholipids, cholesterol, bilirubin, and protein in that order. Great. So what are bile salts? Well, a bile salt is composed of a cation, like sodium, plus a bile acid. Okay, so what are bile acids? Bile acids are always synthesized from cholesterol, and basically what you get when you oxidize or add hydroxyl groups to cholesterol. So the liver takes perfectly good cholesterol molecules and oxidizes them through a cytochrome P450 enzyme pathway, which are concentrated in zone 3 of the hepatic nodule. This forms cholic acid, which is a newly synthesized or primary bile acid, and other derivatives. And these bile acids and bile salts, which contain remnants of hydrophobic moieties of cholesterol, but now have a polar acidic region, act as a detergent and are what allow bile to emulsify lipid particles in the gut so that we can absorb dietary fats. Now, most of these bile acids are conjugated eventually to either taurine or glycine moieties. Taurine is an organic acid, kind of like an amino acid. If you conjugate the bile acid to taurine, that makes taurocholic acid, and if you conjugate it to glycine, it makes glycocholic acid. So again, you take cholesterol, you turn it into a bile acid, most commonly cholic acid, and then you conjugate it further with glycine or taurine, and then you join that bile acid with a cation like sodium or potassium to make a bile salt. But that's not all. In your bile, you also have bilirubin. We talked about that in the video on liver basics. So to review, the bilirubin in bile is derived from heme molecule breakdown from red blood cells and has to be conjugated to a glucouronyl group to become soluble before it is excreted into the bile. And then bile also contains unoxidized cholesterol and phospholipids. We've already discussed the functions of bile over the course of the last few lectures. Bile is important for digesting and absorbing lipids. It's important for excreting cholesterol and bilirubin. Bile is important for copper excretion and in fact is one of the body's only mechanisms to excrete copper. Bile also has some antimicrobial bactericidal activity, and it may help kill bacteria that we ingest with food. Let's focus our attention again on bilirubin for just a moment to complete topics from our previous lectures. Again, bilirubin comes from the breakdown of hemoglobin when red cells reach their expiry date. Initially insoluble, unconjugated bilirubin gets bound to albumin for shuttling through the blood and is carried to the liver where it is conjugated and excreted into the bile. From there, conjugated bilirubin in the bile goes into the duodenum and the small intestine and eventually to the colon. In the colon, gut bacteria start to convert that bilirubin into urobilinogen. Most of that urobilinogen is going to stay in the colon and get oxidized to something called stercobilin, and then will be excreted in the stool. Sterco comes from the Latin word for feces, and stercobilin is what gives feces its characteristic brown color, like a poop emoji. But then a relatively small amount of the urobilinogen that is made in the colon is reabsorbed by the gut, and it enters the mesenteric veins and goes back to the liver along with the bile salts and goes back into the bile. We call this, importantly, enterohepatic circulation, and it allows for important recycling of bile acids to reduce the metabolic demands of digestion. A tiny amount of reabsorbed urobilinogen isn't captured by the liver and ends up in the kidneys, where it is converted to urobilin and excreted in the urine, and this is what makes urine its characteristic yellow color. Now we're going to talk about jaundice and hyperbilirubinemia a little bit. We've talked about this previously when we talked about physiologic jaundice in newborns, and we also talked about disorders of UDP glucouronyl transferase, like Gilbert syndrome and Crigler-Najjar syndrome. but there are tons of other disorders that can cause hyperbilirubinemia. First, we're going to look at some more diseases that cause high unconjugated bilirubin, and then we're going to look at diseases of conjugated bilirubin. There are three big categories of diseases that cause unconjugated hyperbilirubinemia. Diseases of increased bilirubin production, diseases of impaired bilirubin uptake and storage, and diseases of decreased enzyme activity by uridine phosphate glucouronyl transferase activity. So what would cause that increased bilirubin production? It should be anything that causes increased red blood cell breakdown or processing of red blood cell waste. In this situation, we need to overwhelm the liver's capacity to conjugate using the UDP-GT system, and the excess remains as unconjugated bilirubin. Consider hemolytic anemia. This is usually an intravascular process. You're breaking down many red blood cells, so you have more heme to process, and that yields much more bilirubin. In the same vein, we have red blood cell dysmorphias like spherocytosis and sickle cell anemia. Here we have an extravascular hemolytic process. We'll talk about these more in hematology, but blood cell dysmorphias cause increased red cell turnover primarily because of increased splenic clearance. More red blood cells broken down equals more bilirubin produced. Another consideration is hematoma breakdown. Some infants, especially vacuum-delivered infants, have a cephalohematoma, a big collection of blood under the scalp. Given a neonate's already reduced UDP-GT enzyme activity and functionality, it doesn't take much time to overwhelm the system and make more unconjugated bilirubin. The next big group for unconjugated hyperbilirubinemia is impaired bilirubin uptake and storage. The first one here is viral hepatitis. Following viral hepatitis, the liver just isn't taking care of business with bilirubin like it ought to be. So it's taking up less unconjugated bilirubin to conjugate, but the bilirubin that is conjugating isn't excreted into the bowel, so you end up with conjugated and unconjugated hyperbilirubinemia. And then the second bullet is drugs. Certain drugs like rifampin can impair the uptake and storage of bilirubin, resulting in increased bilirubin. Then our last group of disorders are the diseases where you have decreased UDP-GT enzyme activity. We talked about this in the first lecture of the series. We saw this with Gilbert syndrome, with Crigler-Najjar syndromes type 1 and 2, and also with neonatal physiologic jaundice. Then what kinds of things cause high levels of conjugated bilirubin? You can have impaired transport of bilirubin where the hepatocytes can conjugate the bilirubin, but they just can't excrete it. From our first lecture, we remember Dubin-Johnson syndrome and also Rotor syndrome. The next group are diseases that do not originate in the biliary system but cause biliary epithelial damage. This can be seen with various types of hepatitis, as we've said before. Viral hepatitis causes both conjugated and unconjugated hyperbilirubinemia. The other obvious one is cirrhosis. Fibrosis of the liver from chronic inflammation will end up damaging the coexisting biliary epithelial system and its ability to excrete bilirubin and bile. The next cause of direct hyperbilirubinemia is intrahepatic biliary obstruction, where you have obstruction of the bile ducts inside the liver itself, such as with primary biliary cholangitis and primary sclerosing cholangitis. We're going to talk about both of those in a second. And certain drugs, such as chlorpromazine and estrogen, can cause this as well. You can also have extrahepatic biliary obstruction, either from pregnancy, pancreatic neoplasms in the head of the pancreas, pancreatitis, cholelithiasis, cholangiocarcinoma, which is a cancer of the bile ducts, choledocholithiasis, which are gallstones that are impacted or blocking the bile ducts. We'll talk about that shortly too. And finally, biliary strictures or narrowed areas of the bile duct as seen in primary sclerosing cholangitis. Now clinically, how could you distinguish between an intrahepatic biliary obstruction and an extrahepatic biliary obstruction? Say, in a patient who shows up in the emergency room with jaundice. You could do a right upper quadrant ultrasound. An ultrasound should be able to tell you if there is an extrahepatic cause of the biliary obstruction, as in this case, patients would have dilated intrahepatic bile ducts. Primary sclerosing cholangitis. Let's talk about some details of these diseases of the biliary tract. Start with primary sclerosing cholangitis, or PSC. PSC is a disease where you have concentric fibrosis of the intrahepatic and extrahepatic bile ducts. It's obvious in the way it's named. Primary indicates that it occurs without an etiologic insult. Sclerosing means hardening or narrowing, which is what happens as the fibrosis invades the bile ducts themselves of the liver. The pathophysiology is unknown at this time. When you do an ERCP or an endoscopic retrograde cholangiopancreatography on this patient, instead of the biliary tree having a nice, smooth, regular lumen, you see very irregular areas of stricturing and narrowing and areas of dilation that look like beads. This is often described as beads on a string appearance. So when you see that or you hear beads on a string, think about primary sclerosing cholangitis, or PSC. There are a couple of other characteristics that can help lead you to the diagnosis of PSC. PSC is most commonly seen in men around the age of 40. Up to 80% of these patients have a positive P-ANCA, which is an anti-neutrophil cytoplasmic antibody, and it is associated with ulcerative colitis, leading some to believe there is a component of autoimmune disease, although this is currently not proven. And since it's an inflammatory disorder of the bile tract, it increases the risk of cholangiocarcinoma. Next, let's talk about primary biliary cholangitis, or PBC. This was also previously referred to as primary biliary cirrhosis. It's a totally different disease, although the presentation and the name and the abbreviation are just similar enough to PSC to cause some confusion. As mentioned, this used to be called primary biliary cirrhosis, but the newer preferred name is primary biliary cholangitis. You might see either name or both names on your exam. PBC is an autoimmune disease where you have T lymphocytes infiltrating in the liver that subsequently attack the small bile ductules within the liver parenchyma. This causes granuloma formation seen on liver biopsy very commonly. Eventually, PBC can cause cirrhosis, but cirrhosis does not occur in all patients and is only a late manifestation of PBC, which is a big reason that they changed the name, because you can have early stage biliary cholangitis without evidence of cirrhosis and fibrosis of the liver tissue or parenchyma. The demographics of PBC are quite different from PSC. 90% of patients are middle-aged women. Another distinguishing feature is that 95% of these individuals with primary biliary cholangitis are positive for anti-mitochondrial antibody, or AMA. It's important for your test to remember antibodies associated with these two important liver conditions. Anti-mitochondrial antibody for primary biliary cholangitis and anti-neutrophilic cytoplasmic antibody, or P-ANCA, for primary sclerosing cholangitis. And also importantly, PBC can be associated with many other immune disorders, most commonly Sjogren's syndrome, but also CREST and other types of scleroderma and rheumatologic conditions such as rheumatoid arthritis. There is one drug that is mainly used to treat primary biliary cholangitis, ursodiol, or ursodeoxycholic acid, which is a bile acid that has hydrophilic properties. Ursodiol is a naturally occurring bile acid that was originally isolated from bear bile that decreases synthesis of cholesterol in the liver and changes the composition of bile. And in PBC, ursodiol is thought to delay progression of PBC and improve survival, though there is a meta-analysis that shows there's really not much improvement in mortality or symptomatology. Together with ursodiol, there's one other drug that is FDA approved for the treatment of PBC. The second drug is called obeticholic acid, which is also a bile acid. This was just FDA approved approximately 2 to 3 years ago. It's used in combination with ursodiol. Because of its recent FDA approval, it may or may not be on your test. The definitive treatment for both PSC and PBC is liver transplant, but only when patients progress to cirrhosis and develop complications of cirrhosis. Now that we've talked about the primary contributors to biliary cirrhosis, PBC and PSC, let's talk about the secondary causes of cirrhosis. Secondary biliary cirrhosis means there is biliary obstruction secondary to some other process, specifically and most commonly an extrahepatic process that's blocking biliary outflow, sometimes due to pregnancy, neoplasm, gallstones, biliary stricture, or pancreatitis. Any of these things could block the extrahepatic biliary tree, and the pressure that builds up into the intrahepatic ducts slowly over time leads to bile stasis and ascending cholangitis with eventual fibrosis and cirrhosis. All of these diseases will cause direct hyperbilirubinemia and cause resultant darkening of the skin and jaundice, pruritus, dark urine because of conversion of direct bilirubin to urobilinogen, and light-colored or acholic stools because that bilirubin isn't making it into the stool, and there are lower levels of stercobilin. On the labs, all of these diseases can cause elevated alkaline phosphatase because alkaline phosphatase tends to be elevated whenever there's cholestasis or stasis of bile, which results in canalicular injury, and the bile canaliculi is the source of the elevated alkaline phosphatase within the liver. Let's talk in more detail about extrahepatic biliary obstruction such as gallstones or cholelithiasis. First, we should clear up some aspects of naming and vocabulary to improve understanding. There's cholelithiasis. Lith is stone, so cholelithiasis is a gallstone. There's cholecystitis. We said the cholecyst is the gallbladder, and itis is inflammation or infection, so this is inflammation and or infection of the gallbladder. And classically, this is inflammation of the gallbladder due to infection, just like sinusitis, bronchitis, and meningitis are typically caused by infections. We've already mentioned cholangitis, which is inflammation or infection of the biliary tree, and choledocholithiasis is gallstones that are stuck in the bile ducts. So make sure that you understand these terms. Let's talk about gallstones. In the U.S., more than 10% of people over the age of 50 have gallstones, and most of these people are completely asymptomatic. The classic risk factors for gallstones are the 4 F's: fat, fertile, females, and 40. Fat means obesity because dysregulation of the bile acid to cholesterol to bilirubin ratio increases the likelihood of gallstone formation. Fertile because pregnancy increases the risk of gallstones, and the more times you're pregnant, the higher the risk. Oral estrogens and oral contraceptive pills are associated with a slightly increased risk of gallstones as well. Women have more gallstones than men, and a vague notion that most people who get gallstones are over the age of 40. There are also several different types of gallstones. There are stones that are composed primarily of cholesterol. There are pigment stones composed primarily of bilirubin and bile pigments. But most gallstones are what we call mixed stones, meaning they have a mix of cholesterol and pigment. Gallstones form in the lumen of the gallbladder when cholesterol and bilirubin precipitate out of the bile within the lumen. This can be due to stasis, but is thought to be more strongly contributed to by an imbalance of the bile acid cholesterol bilirubin ratio. But as long as the stones stay in the gallbladder, they are not a problem. Gallstones mostly cause problems when they come out of the gallbladder and obstruct the cystic duct or biliary tree. Biliary colic is a condition in which you get right upper quadrant pain because a stone temporarily obstructs either the cystic duct, most commonly, or less commonly, the common bile duct. If a stone is obstructing the biliary tract, you'll get pain when you eat because CCK release stimulates gallbladder contractions, and that increases the pressure in an obstructed closed biliary system. And this can cause pain, classically in association with eating fatty foods. That's biliary colic, right upper quadrant pain due to gallbladder contraction with eating. And that in and of itself is an indication to remove the gallbladder, though it's not an emergent indication. Gallstones can also cause something called pneumobilia, which is where you get air in the biliary tree because a fistula forms between the gallbladder and the small intestine. And a gallstone ileus occurs when an exceptionally large gallstone goes from the gallbladder into the GI tract and causes intermittent obstruction, most often in the distal, most narrow part of the small intestine or the ileum. It's not very common, but it does happen. The diagnosis of gallstones is primarily with right upper quadrant ultrasound. Here you see an ultrasound, and you can see a big oblong black area. That is the lumen of the gallbladder. And then these white hyperlucent areas with shattering are gallstones. They're free-floating, so they've sort of settled to the most dependent part of the gallbladder. Another way to determine if a patient is having biliary colic is to do a HIDA scan, which is a radionucleotide scan of the biliary tree. You inject a radiolabeled substance called HIDA into the patient, and the HIDA gets taken up by hepatocytes and excreted into the bile so that you can visualize the gallbladder and biliary tree. An inability to visualize the gallbladder with this test indicates obstruction of the cystic duct and thus acute or chronic cholecystitis. This is a HIDA scan from a 35-year-old woman with Crohn's disease who is having abdominal pain. So they injected the HIDA and they scanned her at 15 minutes. And you can kind of make out the outline of the liver because the hepatocytes are initially taking up the HIDA. And this dark spot is the gallbladder where all that HIDA is being dumped into the bile and being stored and concentrated in the gallbladder. Then they scanned her again at 30 minutes, and here there's less HIDA in the liver and more in the gallbladder, and you also start to see some of it coming out of the gallbladder and into the duodenum. Then at 45 minutes, there's more in the small bowel and very little in the liver at this point. And then at 60 minutes, they give a shot of CCK, which as you know causes the gallbladder to contract, and they measure the amount of HIDA that is injected into the small bowel at that point to give us a number called a gallbladder ejection fraction, which is a measure of gallbladder health or function. So this is a normal HIDA scan because the cystic duct is not obstructed and a normal amount of HIDA is ejected from the gallbladder into the duodenum. Another major complication you can get from gallstones is cholecystitis. And I want you to make sure you keep cholecystitis separate from biliary colic and the next thing we're going to talk about, cholangitis. Very different topics. Cholecystitis is an infection and inflammation of the gallbladder. The classic physical exam finding in cholecystitis is a positive Murphy sign. This is where you put your hand underneath the patient's rib cage on the right upper side and press up into the gallbladder fossa, and when the patient inhales deeply, it hurts so much that they cut that deep inspiratory breath short. What we're doing here is causing further impingement on an inflamed organ. You have pressure from your hand on one side and pressure from a diaphragmatic excursion on the other side. If the patient can't take a full inspiratory breath, then we have a positive Murphy sign. Cholecystitis is most commonly due to gallstones, but rarely it can be due to ischemia or viral infections like CMV or cytomegalovirus. This is referred to as acalculous cholecystitis or gallbladder inflammation without stones. Importantly, we need to remember that biliary colic is intermittent pain that occurs with eating and is secondary to intermittent obstruction of the cystic duct during gallbladder contraction. The patient does not have an infection and should not have acute gallbladder wall thickening. Cholecystitis, on the other hand, is a clinically infected state, usually because of gallstone obstruction of the fossa on a continuous basis with bacterial overgrowth. These patients will be febrile, can have an elevated white blood cell count, and elevated bilirubin labs, and possibly elevated alkaline phosphatase. On ultrasound or CT scan, you will see thickening of the gallbladder wall, pericholecystic fluid, and fat stranding in the gallbladder fossa in severe cases. The treatment of cholecystitis is to first give antibiotics, usually intravenously, to cool off the infection and then remove the gallbladder several days later. Okay, let's talk about cholangitis, which is inflammation or infection of the biliary tree. This is also most commonly caused by gallstone migration into the biliary tree, also known as choledocholithiasis. The stone usually gets lodged in place, and any bacteria that are trapped proximal or behind this stone are going to have a chance to start multiplying and making pus, and that's what cholangitis is. Treatment of cholangitis is ERCP with removal of the stone and pus and then a cholecystectomy, or a cholecystectomy with intraoperative cholangiogram. That's visualization of the biliary tree through contrast injection in a antegrade fashion directly into the cystic duct and common bile duct to assess for any further obstruction or stones. The hallmark symptoms of cholangitis are important and are known as Charcot's triad of cholangitis, which is composed of jaundice, usually much worse than in cholecystitis, fever, and right upper quadrant pain. There's also something called Reynolds pentad. Reynolds pentad is Charcot's triad of jaundice, fever, and right upper quadrant pain, plus 2 other signs. It's a pentad, and pentad means 5, just like triad means 3. So Reynolds pentad is Charcot's triad, plus more severe symptoms, including hypotension, which is indicative of septic shock, and altered mental status. And remember, this is Charcot's triad of cholangitis. There's also a Charcot's triad of multiple sclerosis. What's that triad? Tremor, nystagmus, and scanning speech. All right, guys, you made it through the new material. Let's do a quick end of session review and wrap up our lecture. First question, what is the fate of bilirubin after it is conjugated and secreted into the GI tract? The bacteria in the colon convert it to urobilinogen, and most of that is excreted in the stool as stercobilin. A little bit is reabsorbed and recycled into the bile via the intrahepatic circulation, and then a small amount is excreted in the urine as urobilin. Next, what are some of the intrahepatic and extrahepatic causes of biliary obstruction? The intrahepatic causes are primary biliary cholangitis, primary sclerosing cholangitis, and drugs such as chlorpromazine and arsenic. And for the extrahepatic obstruction you have pancreatic neoplasms, primary sclerosing cholangitis. Remember, this gives both intra and extrahepatic biliary obstruction, pancreatitis, choledocholithiasis, cholangiocarcinoma or cancer of the bile ducts, and benign biliary strictures. What is the difference between primary biliary cholangitis and primary sclerosing cholangitis? PBC has a positive antimitochondrial antibody. It's usually seen in middle-aged women, and it's an autoimmune disease and is commonly associated with other autoimmune diseases, including Sjogren's syndrome or Crest syndrome. PSC is associated with positive P-ANCA. It's primarily seen in men over 40, and it's associated with ulcerative colitis and cholangiocarcinoma. And there's the characteristic beads on a string, intrahepatically and extrahepatically dilated bile ducts on ERCP. Last one. What are some of the risk factors for the development of cholesterol gallstone? It's the 4 F's: fat, fertile, females, over 40. That's the end of this session quiz. Thanks for joining me.